Assalamu alaikum. Good morning, everyone. I'm Safa Fawaz. I'm an ocularist and optometrist at Orbital Center and Medicare Royal Hospital. Today, we'll navigate some dilemmas in ocular prosthetics, and we'll see the best way to deal with them from the ocularist's point of view. A prosthetic eye actually does more than just replace what was lost. It helps restore confidence, natural appearance, and often is life-changing. But despite these benefits, some sockets, they present certain dilemmas where the prosthetic eye doesn't fit or doesn't sit or function easily. And this is where the experience and the skills of the ocularist become essential to balance the cosmetic demands with functional outcomes and patient expectations. When I say dilemma, I mean troubles that don't have straightforward fix. And here we need to make some compromise and trade-offs. Starting with pediatric fitting. Actually, pediatric cases, they present special dilemmas. The sockets are small and still growing, so this means we need to keep changing the prosthetic over time. And sometimes retention is poor because, especially if the child is active and he knows how to unsecure the prosthetic from its place. The big challenge here is to guide facial and orbital growth with family expectations. So we start by using expanders or progressively large conformers that stimulate the growth of the socket. This might take time, up to years, till we reach the same size of socket in both eyes. It's also very important to start customization at an early age to help the child avoid any psychological impacts. Then we move to rotational instability. The prosthetic eye usually should sit in one stable position, but if we have the periphery is round, or we have socket shrinkage, or even if the patient has no implant, there is a possibility of rotation over time. So in this case, we reshape the prosthetic to overcome this by making it more triangular or elliptical in shape rather than round shape. Also, we can realign the posterior surface so it will be engaged to the coming socket irregularities. Moving to the next dilemma, which is a superior sulcus deformity. It's like hollow or indentation above the upper eyelid area. It causes sunken appearance of the prosthetic eye. It could be caused by orbital volume loss, socket contraction, or even poor prosthetic fit. My approach in this case is to increase the thickness of the superior area of the prosthetic eye by adding more material superiorly behind the upper lid to compensate for the lost fat. It's also very important to blend carefully this added material so we will still have natural contour. Moving to lag of thalamus, which is the inability to fully close the eyelids. In this case, the patient can't fully close the lids because of the big size of the prosthetic eye or any problem with the lids like lid tightening or any other injury. But it's very important to balance the eyelid closure with the full contour. But we will not sacrifice the total cosmetic result by making the prosthetic eye more smaller. So we reduce the size up to acceptable degree, and the remaining lag of thalamus we can teach the patient how to overcome by using sufficient lubricant drops and proper cleaning. Upper eyelid ptosis is very common to be seen with prosthetic fit, usually due to orbital volume loss, weak levator muscle, or if the patient hasn't worn any prosthetic eye for a very long time or is just using stock-made eyes. The solution here is to use two steps. First, we create an edge for the upper lid to rest over by making the anterior surface as conical as possible, creating corneal bulge. Also, we can reduce the thickness under the upper eyelid to help the lid rest over this edge. Also, we need to monitor socket changes over time to adjust anything accordingly. Sometimes ptosis could be seen only in the medial part, and in this case, the corneal bulge will be in the medial superior part of the prosthetic eye. The last one is double dilemma, where we have ptosis with orbital fat loss. This is a special dilemma because they have opposite solutions. So we need to carefully balance the edge design for the ptosis with the compensation of fat loss by adding material. So we start first by creating the edge very carefully and determine where the lid should rest then we can add material gradually under the upper lid without affecting the edge design, and frequent adjustments can be needed. In conclusion, we could see that ocular prosthetics, it's full of dilemmas. There is no one size that fits all, and it's all about the expert and the skills of the oculist to use customization, functionality, and balance the total cosmetic effect. We will conclude with this video that shows how proper fitting could be a real life-changing. Could we have the sound? So we could see different dilemmas, but the proper fit will still give the natural appearance we need. It's okay to let some kids, they participate in some steps, they will feel more comfortable. Also, the proper fitting will give a very acceptable movement of the prosthetic eye. That was all for today. Thank you. Any questions?
Excellent presentation as usual. Any questions? Anyone wants to? Yes, please.
Thank you so much for the presentation. Nice work. I just want to know how we can improve the eye movement of the prosthetic eye. Like we have prosthetic eye, how we can improve there is.
When we take it by impression, this is like 90% of the possible movement we give. Like we take the impression of the current socket, so the prosthetic eye will fit exactly on this socket. This will give the best movement for the situation. There is not all the cases will have same movement. It depends on the case and the dilemmas they have. If they have any implant or no, it depends.
If there is already the ball is implant already, so there is any specific techniques for that one also to follow, or we can give the prosthesis already on surgery done?
No, if he has any implant, then we can expect better movement than patients who don't have any implant. But once it's taken by impression, we won't change anything with the posterior surface. So the possible movement with the socket itself, it will be given.
Thanks for the nice talk. I'm Dr. Yassine, an oculoplastic and a pediatric ophthalmologist from Palestine, practicing at a university hospital. So my question about patients with microphthalmia, what's the earliest age that you would start doing socket reconstruction for them, or like doing the prosthesis, and how easy is that? What's the frequency of changing the scleral shell for them?
Yeah, we can start as early as possible. We can start like 2 months, 3 months, we can start. But how often we change, it depends on the child's growth rate. Like we keep close contact with parents. When they see that it's coming a little bit smaller or an irritation happens, then they know that they should come. Maybe first they come each month, then every 2 months. And it depends as the child grows. But keep contact and keep close contact with the patient, so you will know when it's the right time to change.
And when you consider like a customized prosthesis for the patient?
Yes, actually, to make the parent and the child avoid any psychological impacts in the future. Also, it depends. Maybe in microphthalmia, first it's like very small opening. We can go for conformers just to expand. After that, once there is like enough space to present the eye inside, we start customization.
So, I mean, do you have like an estimate age for the customization? Is it like 2 years, 3 years?
No, I can start earlier. We can start 2 months, 3 months customization.
Got it. Thank you.
the answer. Doctor, you're practicing here in UAE, in Palestine. Nice meeting you. So I have three comments. First, because I'm an oculoplasty guy. So the oculoplasty, this lady is an artist. So one thing about the answer of why you are postponing the customized prosthesis. We are postponing this because first the cost, second the availability because they are not available. Because always we love to have a customized prosthesis because the ready-made is just to cover the gap. The question of Mr. Abadi, he left, I think, about the motility. The motility, as everything in our practice as pediatric and oculoplasty people, we are always in collaboration with optometrists, orthoptists, ocularists. You are our heroes. We are working together. Don't underestimate your work because her work is to meet the implant or the eye itself with the prosthesis. So when you put a ready-made, you are not making the contact between the eye because it is not enough contact. Because if you have a very good evisceration or enucleation and implant, muscles are there. So, and you have a very nice shell, they will be together, they will move. So the eye will move only when you have a good work from her and a good work of you. The ready-made will not make this joint. It will not make the joint. So the joint is the key on the motility. So when they are asking us when we're juniors to put the maximum size, and she's fighting with me saying, okay, this is very small, and she is covering my defects. The same what is the second comment when she is covering my defect in ptosis, because the most horrible ptosis to do is after an eviscerated eye, because there is no support. You are not having a true levator problem. You have actually no back support. So she is covering us with the support. She is doing the lead lag. She mentioned a very nice actually things. The lead lag, the eye is not able to close. We are asking her to make the eye not able to close sometimes because what you are going to have exposure. You don't have a problem of exposure at night. So you are in need of big stimulation of the orbit, big stimulation and less repeated changes of the shell. So you want bigger one and it will be taken. You know that the socket will grow. So you are giving bigger and justify the lag instead of making more stimulation. Much better, right? So all the points they are doing, they are actually covering our backs and are covering all of us. So you will always have a cover of your work by them. They are completing all the defects which we cannot solve surgically. So this is why you are going to give her the case and she will maximize the solution. What was irregularity you have. You got my point. And this is what she's doing, Toli. She's really an artist.
Thank you, Doctor.
Yes.
Thank you. So I have another question about the scleral shell. Exactly. When you have like some corneal sensation, is there like any way of doing the scleral shell and the patient would tolerate the scleral shell without, especially for patients who are refusing the evisceration? So is there like any solution of that?
We can start trying if the patient can hold or no. Sometimes we can make the corneal unit a little bit elevated from the patient's cornea. But if sensation is still there and the patient is not tolerating, then we'll refer for the flap.
The solution is for you. This time is not her. Because when she is doing that, you will have much less motility. Because you are going to lose the shell. What we are doing is whether to do a very simple procedure, 2 minutes, which is with the cautery, remove the epithelium. Remove the epithelium with the epithelium of the cornea with your cautery. Thank you, sensation is done. No more sensation. 2 minutes with your bipolar cautery. Remove your epithelium, done. No sensation, she can put whatever she wants. Mm-hmm. Number 2, if the patient doesn't want even periotomy, cut the conjunctiva, dissect, close the conjunctiva on top of the cornea. don't do evisceration. Just close the conjunctiva on top of the cornea, cover properly, 10 on first, because the conjunctiva will retract. 10 on first, and don't put artificial eye except after 3 weeks, 2 weeks. So the healing will go, the sutures will be correct. And even you can suture underneath to the cornea, so it will be very tight. We are doing conjunctival cover or number 2, epithelial debridement. This is surgical, and let her put the size what she wants.
Okay. Thank you. Thank you.